So, hi everybody, welcome. We're gonna leave a couple of minutes so people can get into the platform. We're gonna be in YouTube as well. We're gonna have translation into Spanish from Dr. Hernandez from Guatemala, who we really want to thank him. He gave us his time just to translate to people who are not comfortable with English. So we're gonna start asking you guys, where are you from? How is everything? Where you are, how are you managing COVID? Hope your guys doing great. Today is a different time for a webinar from Ophthalmo University, but there is a lot of people, who want to know about this amazing topic. Many people tell us that they're going to be in YouTube. Uh, so we have people from Uganda, if I'm not mistaken. Ahmed, welcome. Fernando from Chile, Uganda, Pittsburgh. So we have people from everywhere. Welcome, guys. Hope you're doing great. We will love to hear your thoughts, and from Argentina as well. Um, what else? Surviving and thriving, keeping the family safe, everyone happy. Amazing, Patrick. Thanks for being here with us. Tell us where you're from too. We will love to understand where you guys are from, because today it's talk that we want to personalize from where you guys are from, right? There is many different realities around the world, and I think this is an amazing topic you can apply wherever you live. So I'm gonna start moving for matters of time. We're gonna start this virtual class with Dr. Oeting. A couple of weeks ago, we had this idea. We wanted to build an amazing team of colleagues who were passionate about this topic. Juan Jose also was with us a couple of weeks ago in a webinar talking about bilateral cataract surgery, and he said, "Oh, you need to come with us and talk about this. This is a very interesting topic." Uh, we're going to talk a little bit about our logo and what about Ophthalmo University is. We have a new logo with the O and the U together, because we like to share knowledge, and we like to share quality knowledge. We have this mantra that we want to give people quality content, and then you guys can make up your minds, right? Uh, People ask us, what is Ophthalmo University? And for those who love software, I like to talk about an open source platform in which you have your ideas and you can plug in this big community and share these ideas to the world. And they can be talks, but can be tools for colleagues or many other things. People say, and how you organize? Well, we have this new living system logic way to organize ourselves, basically adapting all the time, and people with their own expertise trying to fill all the holes. It's not like a vertical or organization, but an horizontal one. And we define ourselves as an ecosystem, right? A hub to learn from each other, to try to share knowledge and be stronger together. Social media is our communication channel. It's very nice because in social media we're posting all the time what we're doing, what we're doing next. So please follow us. Facebook, Twitter, Instagram are our most important channels. But we really get some seconds to talk about LinkedIn, because we think it's a platform for colleagues, industries there, colleagues from all over the world are there, and we can, actually we're doing a WhatsApp, a LinkedIn group, sorry, and we are sharing a lot of interesting content and tools. So everybody who doesn't have LinkedIn, it's like having a CV online. I recommend you guys to have it, updated. Here, for those who are there with us, they can, put your cameras, take a picture, and this is a direct link for the LinkedIn group. Uh, uh, we're going to be on YouTube, and YouTube right now is what we call a virtual library. Actually, this talk, the important thing about it is going to be there. So you guys, you don't need to know everything. You need to know what the good quality content is, and you have a direct access. So every time you want, to talk about the concepts we're going to talk about today, you go back to the YouTube channel and you can have this virtual library. This is the quote of the week. I don't know if you guys know Ray Dalio. It's one of my favorite writers, and I think today it applies a little bit, right? He says that it's not actual pain. It's when you are struggling with something, but you really have, a nice way to reflect on it. That's where progress comes. I think it's an amazing quote, and today we can apply it a lot. Today we're going to talk about uh, um, an interesting topic, and I think we should talk about three or four things first. The first thing is about confirmation bias. It's about how we are wired as human beings, and I think this is very important because we all fight for new ideas, right? It's hard for us, but why? Because the way we are wired is not because we're bad or we're mean or anything. So I think today is a day to be very open-minded and to evaluate evidence in the best way, and not only try to find evidence that works for us, but the evidence who has good quality and it's and it's believable. The other thing, and I think it's very important, if we think how we are wired, we need to remember that we have, I'm pretty sure that some of you are familiar with this three brains, right, concept. We're not only, the neocortex and we like classical music and we are very, so we also have a limbic brain and a reptilian brain. And these brains, can be sometimes the emotional side of a matter can be negative sometimes from us when we're hearing a new idea and a very important uh, topic with good evidence. So please have that in mind as well. Another thing that I was thinking, when we were preparing this talk, is about, do we talk with our patients? Do we dialogue with them, and do we ask them what they want? So do we have do we make a decision with them, right? They understand what's happening, they understand the risk, and they understand the benefits, and they help us into that decision. This is about what I love. A couple of years ago, we all started about talking about the comfort zone, right? And again, we are wired a certain way. Sometimes it's hard to leave that comfort zone, but I think today is a good day to step out and to be open-minded about this. This is the other one. The idea, I think, is going to be in the minds of many, who are going to be listening to this, endophthalmitis, bilateral endophthalmitis. Oh man, this could be so hard. So again, uh, we know you're going to have this in your minds, but you're going to hear evidence that's going to be very, very interesting. Finally, we're doctors. We don't like to talk about, the business side sometimes and the reimbursement and how much money we're making. But in this specific topic, there is some concepts involved about how we can earn from the procedures that we do. We're going to talk about that too. And finally, the most important things, when we have this amazing author for a couple of years ago. Actually, I like his haircut. I think he was like a kind of a rebel, a millennial in his era, Arthur Schopenhauer. And he will say that every truth will have, first is gonna be ridiculized, second, people are gonna oppose to it, and the third stage is gonna be accepted. So just to begin, remember, guys, we have this community called Fake Mentors. For those who are there, have your cell phone again. You take a picture. You're gonna enter this WhatsApp group. That it's an amazing community to share knowledge, and it's an honor to me today to have Dr. Steve Arnishoff from Canada. Somebody who knows a lot about this topic. Dr. Thomas Oetin, we have been doing amazing things together for the last months. And Daniel and Quinn, are two amazing surgeons from US who are doing bilateral cataract surgery, and they know a lot about this subject, and I think they're gonna tell us amazing stories And Juan Jose Mura from Chile, is going to help me to moderate this amazing discussion, because he has a lot of experience with this. So guys, I'm going to stop sharing my screen so we can see everybody. Thank you for being here with us. And oh, Queen, you're here. How are you?
Hi.
Great to have you here too. Queen had many important things to do, but she's here with us. So thank you. So we're gonna start. Before Steve starts, we're gonna ask the public 3 questions. Okay, that's gonna be very important. So take a couple of seconds to answer them. And Steve, if you can, you just can start sharing your screen, and we're gonna hear you.
Okay.
So Juan Jose and Tom, you can help me, to talk about the results of the voting when it's done. Let's give a couple of seconds so people can answer. Just to say, there's people in YouTube. They can, they can write some questions, some answers in YouTube, and we're gonna be looking close to that. And please share the results, Lisandro. Tom, can you help me talking about the results of the questions?
Well, yeah, I think it's interesting that people think there's 10% penetrance of bilateral surgery. I would think it would be less than that. We're going to find out from Steve in just a few minutes, but my gut is less than that. But I'm glad to see people don't consider it a super rare thing. And then I love that second question from Daniel Trevine and you, Ivo. It's such an interesting question because it's so hard to get our hands around really rare things. It's hard to grasp them. And so when you talk about a really rare thing like bilateral endophthalmitis, it helps to compare to something else that's really rare, like dying in a car wreck. And here in Iowa, where we're asking people to drive to come see us in bad weather and stuff, this is a really relevant question. And 10x, I think we'll find out more from both Steve and from Daniel about this number, 10x. I don't want to give that up right now because it's a very interesting point, but I think we're going to find out more about it. And 10x shows, I think, that people realize that the bilateral endophthalmitis is pretty rare, and I'm excited to see that. I'm excited to see that people, at least about half the people that have responded thought that. So, but this is a really cool question. I think everyone should pay attention during the next few talks because the answer to this one's going to come out soon, which is fun.
Well, Jose, you have any comments before Steve starts?
Yeah, it's there a very interesting exercise was did in the UK about the visits to the post-op controls and the risk of we're going to see absolutely in the presentation before that, but after that, but I think it's something like 3 times more risk to die in a car accident than have a bilateral, endophthalmitis. And actually, I think for me, it's sad to see that the frequency of a bilateral surgery is low in the world. This is just a few countries when you can find decent numbers. In Spain, specifically in Canarias, they have 80% of a bilateral surgery. That's because they arrange with the Ministry of Health and they demonstrate, the low risk of complications and the benefit, and cost benefit and everything. And in Chile, it's very uncommon. I did bilateral surgery for 3 years. I think something like, I don't know, maybe 500, 600 patients. And sometimes 90% of my patients were to bilateral surgery simultaneously. And after that, I changed my practice at a different clinic, and the staff there decided that we can go for bilateral surgery because of the risk of bilateral endophthalmitis. So actually, I'm doing just no simultaneous surgery, just sequential. So, but I'm very enthusiastic. I think that's the future, especially in those times of COVID. You know, it's very important to reduce the number of controls, the number of traveling, the numbers of contact with another people, because, you know, most of the people think that's going to end in a couple of months and then we're going to return to our normal life, you know, and that's not true. The normal life, I think, is gone. We're going to be, you know, confronting these kind of things for many years in the future. Probably not the coronavirus, but some virus from, I don't know, maybe manatees or dolphins or whatever. We don't know, but they are there, you know, and they're going to liberate. You know, the Earth want to heal itself, and maybe it's trying to getting us away of the track, you know, and we have to look that in the future. So please.
Welcome, Steve. It's an honor to have you here with us.
Okay, well, thank you very much. You brought up a lot of points for interesting thought and discussion. By the way, there's an excellent book on the pandemic of 1918. And there have been pandemics in the world about one every century for the past 8 or 9 centuries. And the story is they last 3 years in 3 waves. And that'll probably be the same with ours unless we get a vaccine or a very successful drug. So first, I want to thank you for inviting me to take part with this wonderful group of speakers. I'm going to talk to you really about global issues and results in bilateral surgery. And my disclosures are there, but of course, none of them make any difference as to whether you do one eye or 2, so they're completely irrelevant. First thing I want to do is give you a reality check. And reality check is, what's the likelihood of really getting bilateral simultaneous post-op endophthalmitis? Well, as we've looked in our society at global results, we're now down to about 1 in 100 million to 1 in 300 million. So let's go look at the worst case scenario of a 1 in 100 million if you're careful. But what's the risk of dying from a general anesthetic? It's 1 in 100,000. So it's 1,000 times higher. And we take our kids to have their tonsils out. We take people who have disabilities to have general anesthesia for surgery. And we give them 1,000 times the risk of doing bilateral surgery, which is, you know, ridiculous. In Canada, the most common lottery is 649. And the risk of winning that is 7 times lower than the risk of, 7 times higher than the risk of getting bilateral endophthalmitis. So the odds are, if I buy a lottery ticket and then go have bilateral surgery, my chance of winning the lottery is 7 times higher than my chance of getting a bilateral endophthalmitis. So, and the odds of winning lotteries everywhere are not very good. So the odds of getting endophthalmitis bilaterally are also not very good. The odds are really that you'll get bilateral endophthalmitis, if everyone does careful surgery, about once every 20 years in the world, which is not very high. But then the interesting risk, I just did a huge review of driving in US and Canada for a big legal case and a charter case about how we do driving and regulate it. And it turns out the risk of death, if you drive only 1 kilometer on the American roads, which are claimed by the Americans to be the best roads in the world, which of course is debatable depending where you live. We all think we're better, but the Americans think they're the best. So the risk is about 1 in 100 million, which actually is pretty close to the risk of dying or of getting bilateral simultaneous endophthalmitis. So the risk of getting a bilateral infection when you have surgery is, you know, less than the risk of it driving to the grocery store because it's likely more than 1 kilometer. So if you just get in your car and you drive around the block, that's the risk is about the same as getting bilateral endophthalmitis. And if you look at the patients, the current risk being now 1 in 100 million. So the risk of getting bilateral endophthalmitis compared to the risk of dying coming back and forth for the extra visits of unilateral surgery is probably about 100 times the risk of dying in a car accident as there is of getting bilateral endophthalmitis. So we tend to look at the risk and say how terrible it is, but the risk is really negligible compared to other things that we do in life. So why do I do bilateral surgery? Well, it turns out that I've been the target because I was the first in the world to do routine bilateral surgery on patients' request. So, and I've seen every imaginable article, but I haven't seen a single publication which shows that the results of bilateral surgery are worse than unilateral surgery. So I do bilateral surgery because it's better for the patient and it's better for everybody concerned. And I'll tell you a bit about that. So the next question is Now that you're totally comfortable because you won't go blind from infections and you won't get hit by a car and whatever, when should you start doing bilateral surgery? Well, I'm more strict about that because I think you have to be a confident, successful surgeon before you embark upon bilateral surgery. You must be able to use intracameral pupil dilation and be comfortable and have a solution available to you. You must know how to manage small pupils in case it doesn't dilate. You must be good at using OVDs and not just have the cheapest one you could buy in your operating room, but have different ones and use them for different kinds of cases. You must understand your phaco machine, be able to set it yourself. If the nurse sets it wrong, be able to change it and know how your phaco machine works and be proficient with adjusting it and making sure everything works well. You must be good at IA. You know, there are more broken capsules from IA than there are from phaco. And so if you break a lot of capsules with IA, you're not a good candidate to do bilateral surgery. You must have good biometry. You must use good machines and do topography and look at your results. You must select your lenses well and be able to implant them well, not have complications from routine steps. You must use intracameral antibiotics and proficiently and be confident with how you use them. Your incisions must routinely be sealed and not leaky. You must have an excellent post-op drop and follow-up routine. And when you see patients post-op, it should be pretty much routine and not see complications every week you have to deal with. They should just be, hi, how are you? I'm glad you're doing well. When you can do that, then you can embark upon bilateral surgery. So I was the first in the world to publish a large series of routine bilateral surgery where patients elected to have surgery only because they wanted to have both eyes done. I wrote this paper with Yining Strub and Ronit Yagev. Yining is now a professor in Queen's University in Canada, and Ronit is a professor in Israel. And what we were surprised about in looking at 1,000 consecutive patients is we had an extremely low complication rate. The ruptured capsules were 1 in 500, and the other ones were like extremely rare, and it was better than other publications. And I was almost afraid to publish it because I was reporting better results than everybody else had in unilateral surgery. But in the end of the paper, we wrote, well, it's equivalent, because we didn't want to start a big fight. And then I found out that around the same time, there were other people doing things. The Finns decided to have completely elective choice of bilateral surgery on demand by the patient starting in 2002. But the Finns speak Finnish, which nobody else speaks or understands, and they tend not to publish their data in world journals. And so you only meet them at meetings and talk about it, but they rarely discuss it openly in the journals. And then Bjorn Johansson from Sweden had published a paper just around the same time as mine with a much smaller series and looking at doing bilateral surgery in Sweden. And now the Swedes do over 10% of their cases bilateral surgery. And then you just heard about the Canary Islands, where the group in the Canary Islands were doing 80% bilateral surgery and were concerned because some of the Spanish ophthalmologists were opposed to it. So rather than go to the journals, they actually published an article and gave it to the government and asked the government of Spain to pass an act in parliament to approve bilateral surgery as being equally safe and effective in unilateral surgery, which they did in 2006. And this is now the only country in the world which by law approves bilateral cataract surgery. So my story is, I've done about 12,000 eyes so far over the past 25 years as routine bilateral cataract surgery on patient demand. It's about 80% of my cataract procedures. Actually, it's 90%. But the reason it's 80 is because from time to time, the government of Ontario would not fund my hospital for doing bilateral surgery. So I would have groundhog days, which meant that on Wednesday, I would do 20 patients' right eyes. And on Thursday, the exact same people came back in the exact same order to do their left eyes. So they'd only come to Toronto for one visit, but stay overnight in a hotel, which they didn't like, but it was better than coming back 2 weeks apart. So for every one of these cases, I use intracameral antibiotics. I used to use vancomycin in the beginning, and then it became generic in Canada. And the generic, the company even told us causes TAS, but it was selling for $1 rather than 10. And so the government insisted we use it. It was made in Canada. So I had to look for a new drug. So I found Vigamox. And Vigamox is great because it's self-preserved. There's a concern because there were some papers where in rabbits, if you gave a high dose in the eye, in a phakic eye, it could be toxic to some cells like the RPE and the pigment epithelium of the iris. So I dilute it, and in using this concentration, which I settled on after a few years, of 600 micrograms in 0.4 cc's, and basically exchanging the anterior chamber volume, in about 10,000 cases, 0 side effects, 0 infections, it works extremely well. So I thought I was alone, but I've been now taking part in about 30 webinars in the past 2 months with COVID. And an interesting one was actually in French, so probably most of you did not join it. I grew up in Quebec, so I speak French. And Dr. Marie-Ève Legaré from Quebec City is the chairperson there. And her entire department, after I spoke to them in 2013, has now converted over to bilateral surgery. They first did 6% in 2016. And then after they got a few going, just a few before that, they're now up to 60% of bilateral cataract surgeries. All 16 ophthalmologists at Laval University have agreed to do bilateral surgery, and they expect this to just keep going up as time goes on. Interestingly enough, they now are the only other place other than our Bilateral Surgical Society to report an endophthalmitis rate of 1 to 14,500. Our society reported 1 to 16,500, and everyone thought we were lying. It turns out in people who do bilateral cataract surgery well, infection rates are really, really low. But we weren't the first. The first to do bilateral surgery was actually Jacques Davil, who in 1747 was unhappy with the results of couching, which is not surprising because they're pretty terrible. And so he decided to do extracapsular surgery, but he did them all as bilateral surgery. And it turns out he always did the left eye first, which I also do, not because I was aware of Davil when I started, but if you always do the same eye first, you have less chance of having errors of mixing up right and left eyes. And so he did 434 of these, and he deemed an 88.5% complete success rate, which is unbelievably good compared to couching. And that's one of the reasons why we look at Davil as such a fantastic ophthalmologist who made a big difference in ophthalmology. Here's our society, which we founded in 2008 after a few of us were meeting at different meetings around the world. So we had 4 Spanish from the Canary Islands, 2 from the UK, 1 from Sweden, 1 Canadian, and 1 South African, a very small group. But very quickly, once we had a society, we had our group go up to like 30 or 40. And we spent our first year trying to devise documents about what should be safe. And we decided first we should do this, that we should say that if any unresolved complication occurs with the first eye, the second eye should be deferred. An unresolved complication means like a broken capsule and dropped nucleus, not a capsule that became errant and you managed to get it back and it was a bit too big and the capsular exit didn't totally cover the edge of the lens, or not a wound that was leaking but you hydrated and sutured and it was okay. But things that you walk away from the surgery not waiting to see the patient tomorrow to determine if it's okay, and you're not happy totally with the result. And the reason for having that sort of vague restriction is we all noticed that the best time to operate the second eye is immediately after you fix the first eye. And we find that the complication rates are much lower in the second eye because the patient, of course, is exactly the same person with exactly the same peculiarities as the first eye. And a lot of us think that the reason why our complication rates are so low in bilateral surgery is because of the second eyes, where we almost never have a problem. So in 2009, we passed this document in our society, which has now become the global standard of how to do bilateral cataract surgery. And we called it General Principles for Excellence in Bilateral Cataract Surgery. We didn't want to call it anything like guidelines because we thought that was presumptive, making ourselves the authorities. And it was passed unanimously and published on our website and now published there, as well as at the Eye Foundation of Canada, where we published it also. 2 things I want to state I think are important, aside from having total sterility and total separation of devices from one eye and the other, is you have to post the data in the OR where everybody can see it, so that everyone knows if you're doing the right or left eye and what the lens is and all the devices you want to use. And you have to train your staff on biometry so they understand the lens, and the circulating nurse calls out the patient, the name, the side we're doing, and the lens power we're giving as she gives it to the scrub nurse, who then calls it out again, like in military fashion, as it goes to the surgeon. And that decreases the risk of having any errors. I got drawn into many debates all over the world, and some of them were aggressive and some not so aggressive. But finally, in 2014, I was invited to both the ASCRS and ESCRS in the same year to have these big debates with a whole audience of like 5,000 people. And the first person to debate me was Kent Stuyvesant, who I had forgotten I met in 2003 when I was lecturing in Denver. And so when I got up and gave my talk, waiting to be crucified by the Americans who were mostly then against bilateral surgery, Kent got up and said he had joined the Colorado Permanente group, and they had now totally converted to bilateral cataract surgery, and he ended up being a cheering section rather than a crucifying section, so I was quite pleased. But then I went on to Spain, and the meeting was in Spain, I believe, and Jose Guel was my opposition, and I knew that he was in the group opposing the Canary Island group, and he went through all the literature every publication and then said, you know, I can't find a single article showing bilateral surgery worse than unilateral surgery. And his conclusion was, the problem was that he found patients were already trivializing the work of ophthalmologists. And if we brought people in, did both eyes and sent them home fine, they would totally trivialize what we do. But that, I think, is not a good excuse not to do better surgery. So that was an interesting debate. Then when I came back home, I got invited to go to New York to meet this group called Help Me See, which were trying to do small incision cataract surgery in sub-Saharan Africa and some parts of India, some of the more remote provinces, which were then and are still considered the most remote places in the world to do good cataract surgery. They had devised and were making their own instruments. They were making these little kits in New Jersey, and they could do the entire surgery for $50 American. And one operation took 5 minutes, and they were amazingly organized. And they are now proceeding to do surgery in sub-Saharan Africa and some remote parts of India, where others don't get to go very often. And they're having really very good results. So then I came back and I got a phone call from this friend of mine. Avery Rush was a classmate of mine at Baylor in medical school. And we were 2 of the 4 who went into ophthalmology. And Avery's 2 sons, Ryan and Sloan, were starting a process in West Texas where they were actually doing bilateral surgery and figuring out ways not to suffer 50% loss like the Americans claim you get on the second eye, but to change things and make it more efficient. So they were down to where they would actually get paid 20% less, but it took them 15% less time. So they said it really wasn't much difference doing bilateral surgery in the American system, despite the problems of financing. So that was very interesting, and we became good friends again. And then I was invited to speak in 2 meetings, one in India with the founder, this Dr. Sahu, who founded the International Society of Manual Small Incision Cataract Surgery, and then with the Egyptian chapter a week later. And I did these 2 webinars mostly to try to make sure that if you're going to do small incision cataract surgery, you do it safely. And I can assure you that these groups are no less motivated than phacosurgeons to do good surgery. And we had very good discussions and very useful in trying to make sure that others in the world who do manual small incision surgery do safe surgery. So now I'll tell you some of the pearls. One of them is the patients you can do that you can't do easily otherwise. And now I've been doing amblyopic eyes because the patient says, well, I'm lying down anyway. Why don't you just try to fix the other eye? So I've fixed about 100 of those. And I'm amazed that once you correct their refractive error, which is usually quite severe, they end up 6 months or a year later coming back and seeing like 20/40 or so. And they're extremely happy because the eye had never to them been functional for their whole life. And all of a sudden they can see it at 2 eyes. And then you have uncooperative patients. All of these patients and their families agreed to have their pictures shown, where you can do them and you do both eyes and they're actually quite happy and their families are happy. This young man has Duchenne dystrophy, and luckily for him, he didn't die at a young age. And when he came in at age 28, it turns out that his bones are so fragile that they cannot move him from this chair without a special lift, or he'll fracture 5 or 10 bones every time. So it takes a half an hour to actually get him out of the chair. And we have the special lift in our hospital. We lay him down in the bed, did both of his eyes. We focused one eye for far to watch TV and one eye for his iPad. And that really changed his life, and he was extremely happy. He had to drive 400 miles for each visit in a special van to come to Toronto to see me, but his mother was happy to bring him and then take him back able to see. And I do surgery often on anesthetic class 4 patients. Particularly interesting are the ones who are dying of terminal cancer and have 6 months to live and have cataracts from their chemotherapy. And they actually wouldn't mind being able to read and watch TV for the last 6 months of their life. And I've done a number of these people, and they're extremely happy. We give them topical anesthesia, do their cataract, and they're fine. So it's really very rewarding doing these patients. Next thing is be careful. We post in the operating room, either on the computer or on paper, a list of every patient and what lens we're going to use and the astigmatism and things. And I post this, something that I handwrite, not on a computer, and I stick on the microscope in front of me for each patient that I do. So I know the calculation of the lens, the angle of their astigmatism, if I'm going to use a toric or a spheric lens, if I'm going to change where the incision is, every single thing is planned, and I look up and see what I'm going to do for this person's eye. So there's no mistakes. And doing that, we have made no mistakes in 25 years. Next, use intracamel antibiotics. If you don't want to use intracamel antibiotics, don't do bilateral surgery. There are tons of papers showing you how valuable this is. And by 2017, in a big course we gave at ESCRS, We had reviewed 7 million eyes in studies around the world. We're now up to 10 million eyes, and only 2 studies did not show a dramatic effect. Both of those 2 studies use such a low dose in Japan that you wouldn't expect any effect from the drug whatsoever. That's why they didn't show a dramatic effect. I like to use diluted Vigamox because it's definitely not toxic, and you exchange the entire anterior chamber so you know exactly how much you get in the eye. I've been doing it since 2004, 9.5, 10,000 cases so far. It's dose dependent, and at this dose, it kills everything. This is how you make it up. You take a bottle of Vigamox, or you can use the authorized generic, which is Sandoz. It's actually made on the same line as Vigamox, just different bottles. And you take the entire bottle, put it in a syringe. This is actually fluorescein, so you can see it better. And then you add 7 cc's of BSS. That's the concentration you want. You put this syringe in another room where it's sterile, and then the circulating nurse goes and puts about 0.6 cc into a little dish for the scrub nurse to pull up in a TB syringe. She hands it to you with a cannula. You put it in the eye when the operation's finished, and everything is fine. Next, don't believe the myths you hear. People will tell you things about, you're going to get bilateral endophthalmitis, you're going to get this or that. Most of it, when you look at the data, is not true. I told you the infection rate we had in 125,000 eyes was 1 in 17,000. The infection rate in Quebec was very close to the same. And the other claim we have is that you get improved refractive results when you modify the IOL choice for a second eye. Since I bought my first IOL master in 2003 or something, I have not had a single case where I've had to change a lens because of an excessive refractive error. I think I had one where I did a laser to correct astigmatism by a bit, but really not very much. And with new instruments, LensStar, IOL Master, doing topography to rule out form thrust keratoconus or anything unusual in the cornea, and using the new equations, this claim is completely out of date. And unless you use ultrasound and you're not careful, you just never have a problem. And so it's not an issue. Next, if you're going to talk about this in published articles, use the terminology we've devised because that's what the world accepts now. Don't make up your own terms because people like me who have to review your articles in the journals have no idea what you're talking about. So you have to use the names we proposed because everybody else uses them, not because I'm better. Make sure you have a good post-op topical drop regime. It's not only for infection. You don't want the eyes to be inflamed. And if you give this, the patient's eyes will not be inflamed. I give them moxifloxacin, prednisolone acetate, and ketorolac in these doses. I give them 3 mils of moxie, 5 of pred, and 10 of ketorolac. And I tell them to take the drops 6 times a day for the first 3 days post-op. And the reason it's 6 times is it makes them think the surgery was serious. And they don't touch their eye, and they're reasonably careful for 3 days. And I also give them a drop of pilocarpine from a minim, which everyone except for Americans has. And the minim is a little tiny thing with about 1 cc of fluid in it. And I put 1 drop in their eye. If the patient has glaucoma, I give them the minim to take home and take a second drop 6 or 8 hours later. And this is the best drug to prevent post-op pressure spikes because it increases the outflow in case you have OVD left in the eye. And also, by the time the second eye is done, the first eye's pupil is small and they can see. And so I give them that. The moxifloxacin lasts 8 to 10 days, the prednisolone about 2 weeks, and ketorolac 4 weeks. I've had pretty close to 0 cases of CME by doing this. The eyes on post-op day 1 are crystal clear and have no cells in them because this really suppresses inflammation when they start taking the drops 1 hour post-op. And this, what this does, the moxie, is if they do happen to have a small wound leak, this is sufficient when it gets into the eye, which is an article in Press now, to prevent the most common endophthalmitis pathogens from causing an infection. It doesn't protect you against the 2 most lethal, most dangerous endophthalmitis pathogens ever found in the world, but against the rest of them it does. So it works very well. And in Canada, unlike the US, it's actually quite cheap. It costs the patients less than $20 for 2 sets of bottles. So next, so the rationale behind bilateral surgery is that when you do this, you actually fix the visual system, not one peripheral receptor. And the patient gets up, whether they're myopic, hyperopic, they want a multifocal lens or whatever, they can see right away. It's better for the patient, it's better for the family, it's better for society, it's cheaper for the insurer, it's better for everybody. So I'm going to talk for 2 seconds about money. Because due to COVID-19, everyone suddenly wants to perform bilateral cataract surgery because you have to wait too long between patients when you have to clean the room and keep it empty for a while. So COVID-19 decreased the number of cases you can do. But with bilateral cataract surgery, normally you can do about 15% more cases per day. With COVID-19 restrictions, you can do about twice as many cases per day as unilateral cases. So money and time have become big issues. So I wrote a bunch of publications, the first ones in the world, on the cost of bilateral surgery, because I was pressured to do so by Canada, which wanted me to justify how much it costs. So I'll say a few things about money, and not much. First, I think it's appropriate to study the comparative costing and reimbursement of bilateral and unilateral surgery, because every jurisdiction will ask you how much it costs, and you have to defend yourself financially to the people who pay for the surgery. But I think it's inappropriate, and I also think perhaps it's a bit unethical to choose to do bilateral or unilateral surgery because one pays you better. I think you should choose things in medicine on what benefits the patient more. But it's appropriate for us to lobby our own jurisdictions to fund surgery equally and fairly, so that you choose whether to do bilateral or unilateral surgery on the merits and needs of the patient, not on which way you get paid better. That's it for bilateral money. Okay, next, the conclusions. Bilateral surgery is rapidly increasing all over the world. That's why I've been involved in about 30 webinars in the last 2 months. You should follow the Society's general principles for excellence, because it makes surgery safer, and it's now accepted as a global standard for how to do bilateral surgery. The reasons to opposing bilateral surgery have never been verified, and they're not verifiable. The risk of bilateral endophthalmitis is really low if you follow the principles we've published, and if you don't and you're not careful, well, you're going to have a higher risk. The need to adjust the second eye's IOL power based on the results of the first eye is just not a reality if you use modern equipment and modern equations. Money is the real issue, and COVID-19 is a monetary incentive to push us towards doing bilateral surgery, but I recommend that you do it and do it carefully. Thank you very much.
Thank you very much, Steve. It was an amazing presentation. One question from YouTube is where they can easily find the ISBCS principles. They're published, right? But they're
published. You can go to the ISBCS website. Just type in ISBCS. You can go to the Eye Foundation of Canada website, or you can email me. Okay. I fix 2 eyes.
But they can find the principles there, and they can follow it with no.
It's freely available.
Steve, what's your thought on doing bilateral blocks on patients right now if they absolutely need a block?
No one needs a block. I have not given anybody a block for the last 25 years.
Fair.
What you do use for people that are uncooperative is propofol, the Michael Jackson drug, but we have anesthetists there, so they do better than Michael Jackson. Propofol is fantastic for one cooperative patient. You bring in an anesthetist, you give them propofol, they're out cold for 10 minutes, first eye's finished, they wake up and complain a bit, another shot of propofol, do the other eye.
What are your thoughts about doing MIGS, and is there any lens you won't do, any multifocal or any light adjustable lens that you won't do bilaterally?
The more complicated the optics of the lens you want to do, the better the patient will do with bilateral surgery. So if a patient wants multifocal lenses, I tell them that I will only do them if they do bilateral surgery, because I don't want them comparing one eye to the other and complaining for 2 weeks. It's just a big headache. If you do both eyes, they get up, they can see far, they can read, they say, wow, it's great. And the reason is, when they came with the cataract, they had decreased contrast, right? That's what they came for, because they couldn't see well. So when you give them a lens that decreases their contrast, they're not complaining. If they can compare, if you let's say as a refractive procedure, they compare their 2 eyes, then they will compare one eye and say, well, one eye is more vivid for something, the other eye is worse, and they'll complain back and forth forever. So first, I try to discourage patients from having multifocal lenses unless they really want multifocals and they're not doctors or lawyers or people who read all day and are critically want very sharp vision. If they just want to be able to walk around, see without glasses, read without glasses, go to the opera, not need glasses, go to the restaurants, then they're good candidates for multifocal lenses. If they really want high demand vision like a pilot, don't do multifocal lenses.
Hey, Steve, what do you think about the use of post-operative topical antibiotics? It seems like you do choose to use those. We've sort of opted against it with the Intracamel. I'm just wondering, you're so knowledgeable in that area. Why do you continue to use the topical antibiotics when you've given the Intracamel?
Okay, well, it's a medium long story. One of the problems in the US is the unbelievably high costs you have for your drugs. So the drugs that I give my patients, they pay about $20 for the drugs for both their eyes. And I think it's about $200 a bottle for each of the drops in the US. It's outrageously expensive. There's a long story as to why it's so expensive in the US, but we won't go into that. But it's by far the highest of anywhere in the world. We have a publication in Process which shows that when you give intracranial antibiotics, especially moxifloxacin, which actually lasts twice as long as cefuroxime or vancomycin, you get about 37 hours of an effective dose to kill the most common target bacteria. But to kill the two most dangerous bacteria, of which have only been about 5 cases in the world, you only get about 7 hours of efficacy. So the problem is that in some people, and I'm sure, Tom, you're a much better surgeon than me, but I can tell you that if I do 2,000 eyes, it may be that 1 or 2 people have a leaky wound. It's just possible that I'm not 100% perfect on every single eye. But if I give them those topical drops 6 times a day, that keeps the intraocular concentration of Vigamox 4 times higher than the mutant prevention concentration, which would kill every one of those sensitive bacteria for as long as they take the drops. So that I know that for 3 or 4 days, they're going to kill everything except for the 2 most resistant bacteria. Now, if we look at those 2 most resistant bacteria that they might get, if you happen to get those bacteria in all of those 4 cases that have been published, they are exquisitely sensitive to the drugs that we use to treat endophthalmitis. And the reason is moxifloxacin is a drug that targets DNA enzymes, whereas the other drugs that we use are all drugs that target cell wall synthesis. So they work by very different mechanisms. So you rarely have crossover resistance. And so if you do treat them with that and they come back with cells in their eye and you're worried, just give them a shot of intravitreal injection for endophthalmitis and they're usually better in 2 days. So although you may get an infection, you won't get a bad one. And so I actually had a patient in 2010 when we were using a lower dose and we didn't know about those 4 cases with terrible bugs, where we got one of those terrible bugs. And the MIC was about 800 times higher than the usual MIC of staph epidermidis. The patient got an injection and they were like 20, 30 in 3 days. So that's why I do that.
But thank you.
It's like belt and suspenders.
We have a question for the audience now, since we're changing to the next speaker. Daniel, if you want to get ready. And you know, it's very interesting, Steve, because we tend to be dual beings, right? It's black or white. So for people who understand what you're saying and want to start, which do you think are the best cases for them to start doing bilateral cases?
The best ones are the medium nuclear sclerosis ones, because if you have a very soft lens, it's hard for people to cut the nucleus sometimes, and they have a harder time with, let's say, 50-year-olds with not hard, not soft lens. They have a hard time with a very dense lens, but they do best with like a medium, 2+ nuclear sclerosis that they can break easily and fracture easily, and a patient who's reasonably cooperative. You do better if you do bluer eyes first because you can see better, although brown eyes are tougher. So, people regard blue eyes and the white race has always regarded ourselves as superior. The truth is it's a negative mutation and we have all kinds of detriments. We get skin cancers more and all kinds of problems. It was an adaptation to living in the far north and not dying of vitamin D deficiency in winter. But the tissues are much weaker in blue-eyed patients. They have a higher risk of severe problems with IFIS and all kinds of stuff. So I like doing the sort of medium brownish eyes with medium nuclear sclerosis as the main cases to start on, because they're the toughest eyes. The patients often stay still and they're easy to do.
Great. So you can start, Daniel, and then we're going to do the question after you finish.
Perfect. I'll go quick. I just want to say the reason I started was because of all of Steve, the Godfather, Arshinov's data. He's got so much good data and it's just hard to argue with. And then just the support of Tom Oetting for allowing us to start in residency. So I'm just going to quickly talk about some of our experience in the US here, specifically at the VA. And the reason that it was such a big deal is because there are too many cataracts and not enough ophthalmologists. And this is just what's happening in the US, but all around the world, we're having this same issue where there are more and more people who need cataract surgery, and there are less and less surgeons to perform that surgery. So I just wanted to talk about a couple of scenarios in the US. The first is the Kaiser Health Group, and this is a big managed care organization in the US. And so basically what it is, it's a group of hospitals that care for this 12 million people, and they do it for a capitated pay. So the government gives them some money, and they just figure out the best way to care for those people. And in that system, what they found is that by doing ISBCS, they can actually save costs and improve care. And a large study from that group of 25,000 patients, their main question was, well, we know the risk of endophthalmitis is super, super low. We know the risk of CAS is super low. So a lot of people are concerned about this second eye refractive error. And so when they looked at that, what they found is that there was no difference when comparing ISBCS and delayed sequential between the first eye and the second eye, or between the second eyes doing one way or the other. So it really provided more evidence that no matter what way you do it with modern biometry and modern formulas, that there's no improvement by changing from the, if you have a refractive error in the first eye. So the VA health system is another very similar model in that all the veterans in the US get care provided at the VA, and it's basically paid for by the government. The VA performs about 56,000 surgeries at all their sites. And so most of those surgeries are actually done by residents in training. And the VA is unique in that these patients often travel from long distances and that there's long wait times. And so when these patients come, we're trying to limit those visits to as few as possible. And so at our residency program, we decided to introduce ISBCS for these people to help reduce the travel that they had to do, reduce their visits, and increase the time that they get new glasses. So here's our results from that study. Our big question also was refractive error. What happens when residents are doing the calculations, when residents are doing the surgery? Are we going to have big refractive errors and a lot of refractive misses? And when we looked at our data between the ISBCS cohort and the DSBCS cohort, there was no difference in refractive outcomes. And these refractive outcomes are similar to other large published databases of refractive outcomes. And if you really look at all of the studies that have specifically asked this question, not a single study has shown there's a meaningful difference between the second eye refractive outcome between those two techniques. So I think this concern is really just one more reason for people to say they don't want to start. That doesn't hold true anymore. The other thing that was really, really important is that people drive a long way for surgery and they have a lot of post-op visits. And when you have a capitated system with a lot more people needing more surgery, you got to figure out ways to be more efficient. And so by switching from DSBCS to ISBCS, we reduced the number of visits that they had. We got them in their new pair of glasses faster so they could enjoy life and they don't have to wait a long time where they have a bunch of debilitating anisometropia. You know, falls in the elderly is a major cause of morbidity and mortality. And by reducing that anisometropia, we allow people to get back to their lives faster. And, you know, we in Iowa, which is where this study was performed, is a very rural state, and patients travel a long way. And so by reducing those amount of miles traveled, we can actually save lives. Now, there's a huge reason that this doesn't have more penetrance in the US. And what it really comes down to is money. Because it's true that there are ways that you can improve efficiency, but in the US, if you do one eye, if you do both eyes in the same day, then you lose 50% of the reimbursement for that second eye. And I completely agree with what Dr. Arshinoff said, that we have to do what's best for the patient, but we also have other things at play. You know, we have 250 employees in our business, and if we lose, 30% of our revenue from our ASC, it's harder to keep those people employed, and it's harder to guarantee jobs, especially through a time like COVID. So, there is the no money, no mission mantra. And so sometimes the finances have to make sense for things to change. And so what we're currently doing in our private practice is what Dr. Arshinoff talked about, which is same day, next day. Our patients travel anywhere from 50 to 500 miles. They have one of their surgeries on Wednesday, they stay the night in the hotel next door, and they have their second eye the next day. We've done about 1,500 patients that way so far. And there's, again, we looked at the refractive results, no difference in the refractive results in those patients. The other thing is that it completely eliminates the risk of TAF because we're using different lot numbers and everything. The OR is different that day, the scrub is different that day. So one of these freak accidents that could cause a TAF outbreak is totally eliminated. You know, and if we change this in the US to 30% of patients having ISBCS, we would actually save 3 lives per year. 3 people, ophthalmologists could save 3 people's lives just by switching to this and reducing the amount of miles driven. We'd also reduce 580 auto accidents, 180 million miles driven, and $75 million to the healthcare insurers. So, I mean, there are huge societal advantages to doing this in the US. And, you know, when we were talking on our pre-call, unfortunately, some of the world often follows what the US does. And if this really hits critical mass that everyone's doing it, hopefully a lot of other countries will follow. I just want to say thanks again, Ivo, for the opportunity to talk, and we can open it up to some questions and discussion.
Thank you so much, Daniel. Actually, the great story is we saw Daniel in The Voice of Ophthalmology 2 years ago in ASCRS, right?
Yep.
It was such an amazing talk. You know, it was 7 minutes, so strong with a difficult panel, you know, in the US. And I think you managed perfectly. I'm gonna start the voting, you know, for the people. So please start answering the questions. What do you guys think is the biggest reason that bilateral cataract surgery is not done in the US, and if you're not from US, in other countries? So I think Daniel said a lot about it, but it's really important to understand what you guys think. We're gonna wait, you know, we already have 50% of people. There's almost done. Please keep answering. And I don't know if there is any questions from the panel to Daniel. Juan Jose, I know you had a comment to say.
You hear me now? Yeah. I think it's the results are very easy to explain why the results in the bilateral surgery are better, you know, because everybody's looking at you. When you go with some disruptive, you know, idea, all the eyes are over you. So you are more careful with the patients. When you're beginning, you are extremely careful with each patient, and then it turns in the regular thing to do. So I think that's part of the explanation of the better results of the bilateral surgery. In the same line, you know, it's very important to say that the training of the staff is a key point of the process. You know, everybody has to know about the, you know, the recommendation of the ESCBS. Everybody has to know that we have to use, you know, different different brands of the viscoelastic bone or knives of everything, and everybody has to be really into the process, because we have to, you know, go down with the mistakes as far as we can, you know. So it's very important to train everybody, you know, the nurses, the assistants, you know, the scrub nurses.
Jose, and especially but somebody like you, you know, you were in a country like Chile, you were one of the few doing it, right? So everybody's looking at you seriously, right? Even colleagues. Steve, were you able to see the results? There's people still talking about bilateral endophthalmitis. What can we say to them? You're mute. You're mute.
That's how it's always going to be. So people are reluctant to admit that it's money. That's the brief summary. And I agree that everyone does better when they're watched, like Juan said, because when I was doing it, I was like the only one in the world. And everywhere I went, I would be aggressively criticized. I recall one interesting thing was I was invited to the New England Society of Ophthalmology, which is the oldest society in North America. And so I went this night to a dinner, and I sat down, and usually, like, New England is not very far from Toronto, and I grew up in Montreal, so I often know a lot of the ophthalmologists there. And I at this table, and I didn't know anybody. And that was very strange. I'm going to give this talk, and the guys next door I knew, but at my table I knew nobody. So I asked them who they were. Turns out they were all litigation lawyers. So the next day I discovered that they had a team of 6 litigation lawyers, one each from the 6 biggest firms in New England, to come to my lecture to criticize me after I gave this talk. And they gave me like 2 hours. So I gave this talk. It was my first really big talk, arranged by my friend Jack Singer, who was president at the time of the society. And so I talked for 2 hours about all the precautions we took and how we were doing things. And then the society decided to give the lawyers 10 minutes for a discussion they had amongst themselves. So one of them would be chosen to speak about how terrible I was. So I sat there, you know, making a few jokes, killing time for 10 minutes. And then up came this lawyer, and he said, well, you know, people in Boston and Harvard like to think that they do innovative new things in the world. But, you know, in reality, in ophthalmology, we understand that a lot of the innovations we've had came from California and Texas and Iowa, and not really from the Northeast, where they were often the most conservative. Nevertheless, he said that if we want to think that we do new things, and we do in heart surgery and stuff, we should accept that people do new things. And as long as they're cautious, it's perfectly fine. And he said, well, everything I told them was perfectly reasonable. And they had no comment about why they should not do bilateral surgery. Subsequent to that, they decided to give me a Paul Revere bowl. A Paul Revere bowl was, you know, Paul Revere was this guy who drove around on his horse and told everyone that the English are coming. It turns out my family's British. So that when I told my mother that I'm getting this Paul Revere bowl, she told me to throw it out before I came back across the border. so I made a joke when they handed me this bowl. I said that my cousins, who are all in England, I was the first one born in Canada, would not really be appreciative of bringing a Paul Revere bowl to England to show them this thing that I got from the Americans, who were appreciative of my lecture. So all in all, it was an interesting experience.
That's a good story. Okay, so very fast, Queen is going to start telling us an amazing story. The story with Queen is we saw an amazing LinkedIn post from her, you know, in San Francisco, starting doing this kind of surgery and starting. So I think your story is going to be great, Queen. Thank you for being here with us. But before we start, real quick, there's people from the audience asking the panel, or like very fast, if they will prefer bilateral 24-hour apart or 1 week apart. So Steve, what will be your answer very quick to that?
I would have bilateral surgery.
Bilateral. Tom?
Bilateral.
Daniel?
Yeah, bilateral, probably with the light adjustable lens.
Juan Jose?
Bilateral.
And Queen?
Also bilateral, and I would
Amazing.
opt for the light adjustable lens, just like Daniel.
And just another quick one, so Queen can start, Steve. And Dr. DiLazio is asking if you are doing bilateral, which would you prefer to start, dominant or non-dominant, or that's not an issue?
I don't care which eye is dominant, but I always do the left eye first. If you have a procedure where you always do the same eye first, the staff make a lot fewer errors because they know the patient walks in doing the left eye first. In almost every operating room I've been in, it's set up so that the phaco machine is on the right side of the surgeon because most are right-handed. So that being the case, the equipment you use on the right side of the room, and the stuff comes in, the instruments on the right side of the room in the corner. So by doing that, you are more sterile if you do the left eye first, and then you move over to the right eye and nothing goes over the patient's left eye. So the same as Davil, I always do the left eye first. Almost never do the right eye.
Very good question and very good answer. I think it's going to be. So Queen, you can start. Thank you for being here with us.
Sure. Hi, everyone. My name is Quinn. I am a private practice ophthalmologist in San Francisco, like Ivo had mentioned. And I, like Steve, also start with the left eye just because I think it's easier for standardization. And I happen to enjoy operating on left eyes more than the right. So it's not very scientific. But actually, Daniel and I are in similar places in our training. We're both new attending physicians and met on the residency interview trail. And I think the difference between us when it comes to bilateral surgery is that I believe he paved the way during residency training in Iowa to start doing some bilateral cases, whereas I had only kind of heard of bilateral cataract surgery through papers and videos. And so to me, it was a very mysterious type of thing. So like I mentioned, I'm a new attending, but I realized as soon as I started doing cataract consults as a new attending, patients were always asking me if they could get their eyes done on the same day. It was just like a remarkable majority of people. And these are well-educated folks in San Francisco. And when I told them that they would have to wait, 2 weeks between eyes, they were really floored. And I started feeling kind of bad about not really being able to give them a good reason as to why it's not done on the same day. Because, we're all on the same page in terms of it being more convenient for the patient to have these surgeries done on the same day. And so fast forward to COVID, when all of the ORs are closed to elective surgery, I started thinking about the backlog being exacerbated, referring back to the data that Daniel presented to us, and really seriously considered bilateral cataract surgery. But for me, since I didn't do that in residency, didn't have any source of mentorship. And so I actually reached out to Tomo via LinkedIn and got some of his feedback and his thoughts, and then followed up with an email. And then I started, looking more at the data and just like kind of building up my courage, I suppose, to really take the dive and offer this as an option for patients. And I would say that the biggest hurdle for starting these bilateral cases was finding a place that would allow me to do bilateral cataract surgery. So I operate at a hospital and 2 ASCs, and the hospital overwhelmed by COVID patients, so that wasn't really an option. And of the 2 ASCs, one is a specific eye ASC, so they're like really well oiled and have all the protocols down. And the other ASC actually only started doing eyes a year and a half ago. The eye-specific ASC said that it is not in their policy to allow bilateral same-day surgery, and there didn't seem to be much room for discussion. And it was actually the second ASC that I operated at where they were, they weren't super biased in terms of protocol for eye surgery. They were just learning, and they told me that they would be open to it. I showed them the data, the numbers from Kaiser in particular, and they said, if you are willing to teach us how to do this, we are willing to do this with you. And I said, let's learn together. I've not done this before. And as soon as I got the okay from this ASC, I called up one of my patients who was scheduled for surgery. And the first patient I called said, yes, I want bilateral cataract surgery. This is a 46-year-old woman, +2 NS, and I would say she's like a -8. Myope, and so she would have had really bad anisometropia. And with COVID lingering in the background, both of us were a little bit afraid that if we did one eye and waited a few weeks for the other eye, maybe there would be another shutdown of the operating rooms to elective surgery, and she would be stuck in limbo with the anisometropia. And so, she said yes. And then I was very, very, very frank with her that I had never done a bilateral case before. I said, these are the reasons I think you would be a good candidate. And she was, she was already wanting to do it, but also anxious because I was upfront about not not having done this before, right? So we spent basically over from our pre-op appointment to the minute up to the surgery, we spent about 2 hours talking about the pros and cons. And I emphasized to her that at any point in the process, she could change her mind about the bilateral surgery, and we could switch to the standard, do one eye, wait 2 weeks, do the other eye, and really emphasize that if something went wrong with the first eye, we would not do the second eye on the same day. And so, we talked about that. I planned out the procedure. I walked every single OR team member through my planned steps, which I got guidance from Tom on. And then as I was doing all of this, I kept signing patients up for bilateral surgery. Once I started offering that option, patients, the ones who wanted it didn't need to be convinced. There were very clearly, I remember there was one gentleman, he sat down and he said, "When am I getting both eyes done?" And I hadn't even offered him the option yet. And this was before I did my first case as well. And I said, if you want to, we can do that. And these are the pros and cons. And he asked me, "Have you ever done this before?" And I said, "No." And then he goes, "All right, I'll do it. We both must be crazy, but like, I want this bad enough that I want it done on the same day." And so I planned everything out, and the first case went off without a hitch. And it was a little bit stressful, trying to kind of teach the staff to do this, and also not really have a frame of reference from my training, but I just took my time. I think a lot of times during surgery, there's time pressure to turn over the room and do as many cases as possible. I just, I took my time, was like verbalized everything I was going to do, checked in with the patient, and everything went well. And on post-op day 1, she was incredibly happy. She was the least anxious she'd ever been in like our whole doctor-patient relationship, which is like, it spanned almost my entire attendinghood. She was a very anxious person. And then post-op day 1, she said to me, "Wow, I'm so glad I got them done on the same day. I can see everything clearly." And her corneas look good. She was 20/25 with, I think there's like, I actually think she is due to come back in a week to get her final refraction. So I'll have to see where she lands. But overall, it was a smooth-ish process. And I've done some more, and everyone is happy. So I'll continue doing it, but it feels a little bit weird to be the only one here in not even a large healthcare system. But it's something I believe in, and the reinforcements that I get from my patients, especially post-op, is totally worth it.
Thank you very much to share your story, Queen. I think it's so powerful because it's Daniel had the chance to do residency with Tom, and you're starting, you're comfortable with this, but you saw something interesting in your patients. You care about what your patients wanted, right? And then you did the research, you used technology. That's very interesting. And you got in touch with Tom, and you have the audacity to go with it. I think it's I don't know if the panel has other comments, but I think the story, it's amazing. Thank you. Thank you for sharing it.
Thanks for having me.
I think that's great, Quinn. It's interesting because when I started doing them, I was the only one, and I couldn't call Tom. My experience was much like yours because it was driven by a patient. I had this 45-year-old female who came in with bilateral cataracts and told me that she races in NASCAR. And in the winters, she actually was driving for Toyota, testing cars in the northern tundra, northern Ontario. and she only had like a month and a half in between, and she really could not do her eyes separated because she wanted both eyes done before she could go and have a chance to heal. And so I gave her a list of the risks and told her, you know, that she was the first one doing this in the world on her own for her own choice. She said, fine. So I said, aren't you concerned? She said, do you think the risks of this are anywhere near as high as the risks I take in driving 100 kilometers an hour into snowbanks?
This is nothing for me, right?
I guess not, right? And the next day, like you said, instead of her being anxious, the other patients were mad at me because I'd done like 18 eyes, and she was like 20, 25 in both eyes and perfectly happy because they weren't very dense cataracts, but she couldn't see to drive. And the other patients all said, well, how come that beautiful young girl, you did both of her eyes and she's fine, and you're making me come back in a month because I'm an old lady? And I said, well, that really wasn't the idea. You just conned me into doing it. And so then within like 2 months, I was doing everyone bilateral because the patients demanded it from me. It was interesting.
It's
amazing.
amazing.
The same as her story. Yeah.
So I shared, when Quinn was talking, I really shared the principles. There's going to be easy. Everyone who wants them, there's going to be a link, or I can share it by email, whatever you want. Now we're going to have the amazing Tom. It's so, you know, it's so good to have you. Every time we have you here, Tom, you know, we have amazing talks. Thank you for being here with us. We're going to start a quick vote. This is the last one. This was an amazing idea from Daniel to ask this, is when should ophthalmologists can start with bilateral cataract surgery? I think it's a very interesting question. And Tom, I would love to know your story. How did you come to start with bilateral cataract surgery?
Well, yeah, I would like to discuss that a little bit. And once again, I want to congratulate Quinn. I agree with Steve. It's really wonderful how bold she was. It's very difficult to change a practice like this, to fight against the healthcare system that exists. You know, we're not all hockey players like Steve. We can't, you know, we're not as strong as Steve and Quinn maybe. But it's nice to hear your story, Quinn. Thank you for sharing that. I want to talk about a little bit about what we did in Iowa City, but I mainly want to talk about the idea of teaching with bilateral cataract surgery.
Yes, sure. Let's give 2 seconds. There's some people who didn't answer. Please answer very fast the question, and then we're going to share the results. That's going to share the results. So there you have them. You know, there's almost half of the people who think that we should start learning this in residency. That's good, right, Daniel? What do you think? That's very good.
With the right mentor, it can work.
we all need to go to Iowa or Toronto, right?
Well, here I want to show you how much slower I am than Quinn. So we have the biggest lecture we have at Iowa is called the Wolf Foundation Lecture, and it's considered the greatest honor that we have in a lecture. And in 2001, I was in charge of doing this lecture, and we got Steve to come down from Canada, and he told us about same-day bilateral surgery, and it was crazy, wild. I remember thinking about it, and I thought about it, and I thought about it. But it was like 20 years later, not quite 20 years later, but 15 years later before I did it. So Quinn, I just want to congratulate you. You're a million times faster than me at moving forward. But it was an exciting idea, but it takes a while sometimes to move forward. Let me just get the next slide here. 1 second. And you can see there's Daniel Trevine, who was our resident, and he was such a wonderful resident and colleague and friend. Basically, he pushed us to move forward. And what's really important, I think, in what Steve was talking about is the idea that you have to prepare for this. It's not something you just suddenly change to do bilateral, but you got to get your act together. And Steve had a wonderful slide. I don't know if you know this, Steve, but like I was taking pictures of every slide you had. Even now, even 20 years later, I'm still taking pictures of all your slides. But the important point is you got to get your act together with your single surgeries first. So you have to use intracameral antibiotics. You got to get that squared away with your pharmacy. You got to get that done. I think intracameral mydriasis is important. Steve mentioned that in his talk too. The reason it's important is, at least in our experience, it makes it less likely that you use a device, which makes the surgery faster and safer. And so I do believe in intracameral mydriasis. I'm a big believer in sealant. The reason I like sealant is it gives you just a hair trigger to seal the wound. And so there's a little hesitation when you put a suture in. It's going to take a little bit longer. We did a study on this and showed that using sealant saved a significant amount of money in our VA. It saved money because we were quicker to use the sealant. It didn't take as long. We also didn't bring people back at 1 week to remove the suture. And so we found it actually saved money, but that's another story. But I think get your act together with your single surgery first before you move forward. And I think Steve did a wonderful job of talking about that. Now, this process for us at our hospital was helped because Daniel worked so hard with me on this. And so we had to fight a bunch of battles. We had to fight the pharmacy. We had to fight the nursing staff. We had to move forward. And I think it was really because Daniel helped me in that battle that we were able to move forward at all. So we talked about this just briefly. The pro is that there's less travel time for family. It saves money. It's for the family. It saves money for the system. But the real thing, if you want to know, that pushed me over the edge, this is the thing that pushed me over the edge. We had a resident who was doing only cash cataract surgery, only cash. And so there was no issues with insurance or anything. And he found that when he offered, like Quinn, when he offered bilateral surgery, they all wanted bilateral. And these were highly sophisticated people that could choose anything in the world. They were paying like ridiculous fees, like $10,000 per eye for cataract surgery. And it was all cash, and they were sophisticated. And they made this choice. And that's the point I think Quinn's making, is that when you present this choice to patients in a fair and balanced way, they make the choice for bilateral. And so that should make us all think, what would we want? What's the right thing? And then once you get that in your mind, then you may have to fight your system a little bit, like Quinn had to, and like we had to, and like 20 years ago, Steve had to. Teaching is an interesting point. And I think Steve made this point in his talk, and that is that before the surgeon proceeds, you've got to be pretty confident that you can do this without complication. And we decided that 60 cases was the point at which I start considering the idea that this surgeon may be ready to do bilateral surgery. The reason we chose 60 cases is because we did a study years ago at Iowa and showed that there was a tremendous difference in the complication rate between the first 60 and subsequent cases after that. So that's why we chose 60. The cases obviously have to be topical, but really it's important for me as the primary attending with that resident to be confident that they're able to move forward. We're fairly quick to cancel the second case. We cancel about 4 out of 100. I think Steve showed data that he canceled 4 out of 10,000 or something, but we canceled about 4 in 100. They were either too dense on the first case, so I was worried that there was going to be a lot of edema in both eyes. There was a vitrectomy needed in the first case. One case moved a lot and, in our opinion, needed a retrobulbar. But the really exciting thing from a teaching point of view, the really interesting thing is the second case is so very similar to the first case. And so from a teaching point of view, you get this amazing N of 2 that you almost never get. So you work on some teaching points with the first eye, and then immediately thereafter, you can work on those exact same points with the second eye. It's an incredible teaching opportunity. And so if the iris behaves a little bit, if the chamber is a little more narrow, if the nucleus is a little denser in a funny way, you can immediately work on improvement with that second case. And that's a really powerful tool from my point of view as a teacher. Steve talked about COVID. This is really interesting. This is what affected, I think, Quinn. And that is that there's less testing, there's less exposure to the healthcare system. So all the great things that we talked about already that are good about the bilateral are even better in the environment of COVID-19. And so I think this is going to be an accelerator, as Steve mentioned. Just like COVID-19 has accelerated our use of Zoom lectures, just like COVID-19 has accelerated our use of simulation and training. This is a great accelerator. So in summary, I just really appreciate, Ivo, all the things you've done. If anybody's accelerated training in the world during this pandemic, it's you. Thank you for all you've done for these webinars. Get prepared before you do this. Consider the sealant. I really like it, or get really good at suturing quickly. And I do think this is a powerful tool in a teaching program because you can immediately take what you learned from the first case and apply it to the second case, and you can really seal in those lessons right away. You just have to make sure that you're pretty good before you move forward. We arbitrarily chose 60 cases. Maybe it should be more than that, but that's what we have arbitrarily chosen in our program. I want to thank once again Daniel for all you did at the University of Iowa. Quinn, you're such a great force in social media. We appreciate your kind words to us and sharing your story. And Steve, you're the godfather, just like Daniel said. I can't tell you, 20 years ago when you came to visit, I apologize it took me so long to move forward, but you've meant so much to all of us in ophthalmology, and it's always an honor to be with you. So thank you, Ivo. That's all I got.
No, thank you very much, Tom. I think you're amazing points. I never thought about it, but in teaching, I think bilateral cataract surgery has a very interesting place, right? Very, very interesting. There is one question from YouTube about bilateral cataract surgery, in the same day for preventable blindness. What do you know about this, Steve? In campaigns, for example.
I'm not sure what they mean by the question.
I mean, does it have a place? Is it safe to do it with the principals when you're doing campaigns all over the world?
My view of doing things is, if we do it in Toronto or in Iowa or in California, we try to do it as safely as we can. And our goal is that bilateral surgery is our best procedure, in which case it becomes the best procedure everywhere in the world. It makes no difference where you are. It's the same. So if you're going to do it in a remote area, I told you I had 2 webinars with groups doing manual small incision cataract surgery in remote parts of Africa, India. And I spoke to them with the intention of going through the principles and hoping to show them that it's every bit as important to do that, because they do it very well, as you heard from David Chang speaking and many others. They don't have a higher complication rate than we have in phaco. So as long as we go through the same principles and say, look, no matter how you choose to do the cataract surgery, if you follow these principles and you're careful with your instruments and the devices you use, and it's sterile in both eyes, it should be the same and the best choice for everywhere. So I think it is. I actually want to comment about when I was in Iowa, because it's interesting when you go somewhere to speak, the very different experience that I have as a speaker discussing bilateral cataract surgery, where I was attacked everywhere I went at that point, to my experience of meeting Tom for the first time, because he was the host and he invited me, and he was this young guy who was bringing innovative techniques of teaching residents to do cataract surgery. By far the most impressive thing that I saw in Iowa were Tom's ideas about how to train residents. And I'm not surprised that he is, well, if I'm the godfather of bilaterals, he's the godfather of teaching cataract surgery, because he has brought innovation and ideas of how to teach people better. And everyone in the world, not surprisingly, goes to him to ask him how to do this or what should I do. Because I sat there, and after my talk, and then I heard Tom speak, and I thought, man, this guy's a smart guy. He has really good ideas, and he's an amazing teacher. And so I'm really happy to be able to be in the same podium with Tom, because it's just great. And I really admired your work ever since then.
Thank you.
And just to hop on to that, like residents across the country read Tom's book, Greenhorns, that Greenhorn surgery book. And honestly, I was really surprised when I got responses from Tom Moding on LinkedIn and via email. And I was very starstruck. And then when he, walked through the procedure for his cases at Iowa, I felt like I had the backup and the knowledge, at least in theory, to go forward. And it was, it was a huge part in me making the leap. So thank you. And I really also wanted to say that I never thought I would sit on a panel with Steve. So this is awesome. Thank you for this opportunity. And Daniel, I think it's awesome that we met on the interview trail and now today are speaking.
Full circle.
That's amazing.
It's amazing, guys.
And one other funny comment. It's interesting that Tom commented about my hockey experience. I grew up in Montreal when I was 12 years old. At that time, the Canadiens had first claim on any kid who grew up in Quebec to play hockey for them. So I got recruited to play for the Canadiens when I was 12 years old. And I got to play in a league that was like the highest league in Quebec, where you only would play from your city to the other city. I'd play in Quebec City and Trois-Rivières and all this stuff. But I got tough because I wasn't the only English kid on my team. I was the only English kid in the league. I was the only one without a French name. I remember having to get on the bus with all these kids who'd be going on in French about how they didn't want, they mosey anglais to do this and that. And there I was, the English guy on the bus. Fortunately, I was bigger and tougher than they were. And that's probably why I got to learn how to disregard the comments of my colleagues when I do bilateral surgery, by learning to disregard it playing hockey for all those years.
This is amazing, guys. So again, I think, Wayne, what you're saying, technology and getting us together and sharing this kind of knowledge, it's something incredible. There's a very, very interesting question from Dr. Rob Jones about the consent process. He's telling us that since bilateral endophthalmitis is so rare, to what level you discuss with the patient, the risk of it? Did you go into details? What do you do?
What I do is I give the patients all the risks in writing. But when I talk to them, I tell them that cataract surgery is the safest operation in the world. And from all the data we have from sources that do bilateral surgery, the risks in bilateral surgery are actually lower. And I tell them it's, but it's like if you drive your car, you could go under a bridge and a piece of concrete fall off the bridge and kill you. You could get an injection of a drug during the surgery that could kill you in 5 minutes or 30 seconds. There's risk in life. But if you stay home, your house can catch on fire or, whatever. So the risk is extremely low, but it's not zero. And then I say, well, that's the way it goes. And I gave it to you all in writing, and do you have any questions? And I'm happy to discuss any one of the risks you're concerned with. But I tell them there is risk, but the risk is lower than the risk of not fixing your cataracts and maybe getting run over crossing the street. Right? So
there's one last one, and then I would love a quick comment from the panel, and it's about cases you can have a refractive surprise, or you have diabetic retinopathy, or you have other problems, glaucoma. In those cases, you do bilateral cataract surgery, or you just
in our suggestions of doing safe surgery, it says that any other problem they have has to be stable. So I try not to do surgery on unstable glaucomas because they're unstable, and I like to stabilize glaucoma first, because if I fix their lens but they go blind from glaucoma, they're still not very happy. So I try to make sure that they're stable. And if they really have terrible glaucoma, we manage the glaucoma first or simultaneously or whatever. In terms of diabetic retinopathy, that was one of my exclusions. But then the retina surgeons in Toronto began to send me the really terrible diabetics who had bilateral dense cataracts, and they couldn't see their retina very well, but they had macular edema and they had early proliferative retinopathy, and they wanted to get going to attack their retinas to fix them. So they asked me if I would do my bilateral surgery in small incisions that were sealed and tight, and they could go back the week after and start attacking their retinas. So I began to do the really bad ones. And I thought, well, if I do the really bad ones, the ones that aren't so bad. So I now do pretty much all of them. If I have them checked by their retina surgeon and say, well, do you want to give them an injection of an anti-VEGF or, whatever, before I do their surgery? And you can see them again 2 weeks later and continue to manage them. But if they can't see their retina well, there's not much choice but to try to do their cataract so they can see what they're doing.
Great. What about the previous refractive surgery or radial keratotomy? You're just doing
RKs are the only ones that I find are difficult to be accurate on, because their corneas are to use a
Yeah.
not very good term, wonky. They're all over the place.
Unstable.
Maps or anything, they could be anything. But the problem is the right eye and left eye frequently are independent. And so if I go and do the right eye or the left eye first, and I figure out, well, I got them within a half a diopter or a diopter, it doesn't mean the other eye will be the same and I'll have the same result. So they're really independent. And so I just tell the patient, I say, look, you could be off by a diopter or two. And if you are, I'll try to make it so that you're myopic because you're far better off to be -2 than +2. And you're going to change by a diopter towards being a diopter more hyperopic every decade anyway. So we aim for, let's say, -1 or -1.5. And they're happy because they saw so badly before. If I get them to be -1, they think it's fantastic. Because usually they come in there +3 with a 6 diopter cylinder.
I agree. RKIs are tough, but if you have the right technology and are using intraoperative amaurometry, and if you have access to the light adjustable lens, previous refractive surgery is totally not a contraindication in my opinion.
Right. You get them really quite accurate.
Mm-hmm.
Yeah.
Yep.
And if I do someone who has an RK, I'd rather leave them at -1 than at plano, because at -1 they're going to get better. Plano they're going to get worse.
When I talk to a patient with previous refractive surgery, I used to say to them, if I go for surgery for one eye and I have a problem with the lens, we have to go to the surgery again, a second time, and then a third time for your second eye, and then we can go for a fourth time. So if you do bilateral surgery, you can correct all the problem in the second surgery. You have to go just 2 times to the operating room. So it's much easier. As Dr. Arshinov said, both eyes are different. You can have surplus in one eye and nothing in the other. It's more for myopic patients because the hyperopic patients with previous LASIK, it's pretty much there's no mistake in the lenses. It's pretty strange.
Guys, thank you so much. I think Quinn said it. It's such an honor to be in this panel today, and especially that this content is going to be in YouTube in a virtual library, so you can come back anytime to see some details about it. I would love a final comment from the panel. Quinn, you can start, and thank you so much for having you.
I guess I would say, so starting off, thank you again for this opportunity. I am starstruck and encouraged, and I did learn a lot, actually, especially in terms of framing how really low risk bilateral endophthalmitis is. And while you were speaking about it, the question about how to counsel patients regarding bilateral endophthalmitis, I think one thing I really wanted to emphasize and probably end on is that, yeah, I go over the low numbers with the patients, but I also let my patients know that if the worst thing ever happens, if the bilateral endophthalmitis does happen, I'm with them forever, right? I'm not going to abandon them. It is like a terrible thing that is traumatizing for patient and physician alike. And so, it's a complication for the both of us. So they shouldn't think of it as something that happened to them, and, manage it together. And yes, the treatment options exist and the outcomes are good. So ultimately, just to know that bilateral surgery is good for a lot of reasons, but if the worst case scenario happens, it can be managed, and it can be managed as a team rather than like something you receive. And so I certainly am going to continue offering this to my patients.
Excellent. Daniel, final thoughts?
I mean, it's all been said. My final thought is just appreciate your mentors.
Thank you. Juan Jose?
I think, bilateral surgery is an amazing thing. I think we have to change our mind. I think it's the same that happened with the LASIK. At the beginning, the LASIK was used to made in one eye and then the other eye. And now I think everybody's doing LASIK, both sides the same moment. So that's going to happen the same with the cataract, because we have no reasons, you know. When I talk with my patient, I said, what is the risk of endophthalmitis if you go for bilateral cataract surgery? You have the same risk that the patients go for one eye. But what is the risk of the infection of bilateral, both eyes in the same surgery? Well, in Chile, we have 20 million people. I have to operate all the people 3 times to have 1 case of bilateral endophthalmitis. So it's pretty low.
Thank you. Thank you very much. Tom?
Well, now that I know how risky it is to drive from Steve's talk, I'm scared to even go to school. That's the thing.
No, it's no.
First, I really appreciate Ivo, you doing another great webinar. It's really, I know you've got a lot going on your plate. I know you got a new baby and all that kind of stuff. It's I think this COVID is an interesting accelerator of trends. Things like working from your office, things like doing bilateral surgery. Things are changing. And I think we have an opportunity to learn from this period of time. And some of these things we're going to do forever. And some of the things we're only going to do during the COVID. I hope it lasts only 3 years, like Steve said, or less than 3 years. But some of the things I hope they last forever. Like for example, the fact that that I go on more walks and I eat less food than I used to. I don't know why. And the fact that that we get together in these virtual ways that we would never get together, right? I mean, what's the chance of getting Steve Arshinoff to come back to Iowa? It's like 0, right? So it's really this COVID thing is, there's little clues that we're getting, and one of the little clues is what Quinn did in her practice, and that is she said, you know what, it makes sense to do bilateral, and I'm going to go for it. And Steve's been telling this for 20 years. Daniel's been telling me this for what, 4 years, 5 years, and we should listen. Okay, that's the point. That's the point. Let's listen.
Thank you very much. I wanna thank Dr. Luz Marina Melo. She's from Barranquilla, Colombia, an excellent cataract surgeon. Oh, you will not imagine. And she's here with us translating into Spanish. So, the Spanish speaking audience can. So I want to thank her very much. And Steve, your last thoughts. Thank you so much for giving us this time.
Okay, well, I'm not quite sure what to say. It's been a very, very excellent webinar. Thank you for arranging it, Ivo. Everyone spoke brilliantly. I liked what Quinn said, how she said that she would always stand by her patients. One of the things that I do, I have all these other side hobbies I do, and one of them is I do lots and lots of legal cases. I've done like about 150. And in almost every case where the doctor is guilty, the doctor really isn't guilty for anything except for abandoning the patient. So one case today got, the doctor walked out of the operating room and I think ruptured the capsule or did something. And surgery has complications, and you can rupture a capsule. You will sooner or later. You'll have all kinds of things happen to you. So the doctor, instead of telling the patient they will stay with them and help them, said, well, that's all I can do for you now. I'm finished with you. I'm referring you off to so-and-so, and maybe I'll see you in the hall sometime. So she got sued. Big surprise. So I think that was a very good point to tell them, to let the patients know that you're their doctor, you will stay their doctor, and you will take care of them. And patients really like that. And I actually tell all my patients that I'm happy to see them for the rest of their life. I'm not just a surgeon. If they want to come back 5 years later and say, how am I doing, doc? How's my lens? Did my operation go well? Is there any problem now? Do I have any concerns? And they may have pseudoexfoliation, and they may have developed pseudophacodenesis. Things can happen in life. It's not my fault, but they may have that. So I think that's a really, really important thing to say. And I wanted just to tell Tom that I agree with the talks that we all should appreciate our mentors. But Tom, when I came to Iowa, it was a fantastic experience for me, and I'd love to come back. I learned a ton of stuff from you guys, especially from you and the other speakers you had. And I think most of us who are speakers who go around the world and talk about whatever we talk about, you realize that when you go to these meetings and you give a talk, you learn a lot more than the audience, because there are another 10 or 15 talks, and you're parked in your chair and you're off on the podium and you have to discuss with them, and you learn a lot because you're very intense in paying attention to what every other speaker says, whereas you may not be when you're running around in some meeting from room to room as fast as you can. And so I think I learned a lot more in Iowa than they learned. But anyway, and it was a nice place to go, and I got to see how the clinic is laid out and their history and talk about it. And it was really very interesting. And I really enjoyed this, and to see how this Ophthalmic University works. And I think it's tremendous. And it's amazing to see that the young guys are coming out with new ideas to help us spread knowledge of ophthalmology. And it's just been a fantastic experience. And thank you for including me.
Get him on the schedule now, Tom.
Thank you, guys. Thank you very, very much. We had an amazing time. I hope to have you guys here in the platform soon, okay? Have a great weekend.
Thank you. You too.
Thank you. Bye.
Bye-bye.